Pediatric Urinary Tract Infection, UTI Summary. Pediatric urinary tract infections, UTIs, are significant infections involving the kidneys, ureters, bladder, or urethra. Early detection and appropriate management are crucial to prevent renal damage, particularly in children with congenital anomalies or other predisposing factors. Risk factors. Congenital anomalies, such as CAKUT. Gender, higher incidence in females due to shorter urethra, except in uncircumcised boys 12 months where the risk is higher. Voiding dysfunction, including infrequent voiding and constipation. Family history of UTIs or renal diseases. Instrumentation, catheterization, or surgical procedures on the urinary tract. Etiology, predominantly caused by Escherichia coli. Other organisms include Klebsiella pneumonia, Proteus mirabilis, Enterococcus faecalis, and less commonly, fungi or viruses. Clinical features, infants and young children, often present with nonspecific symptoms like fever, irritability, vomiting, or poor feeding. Older children may report dysuria, urgency, frequency, and suprapubic pain. Diagnostics. Key initial test. Findings include leukocyte esterase, nitrites, and microscopic pyuria or bacteriuria. Urine culture confirms diagnosis. Significant bacteriuria varies by collection method, e.g., 100,000 CFU milliliter for clean catch. Imaging renal and bladder ultrasound ROS is first line. Further imaging, e.g., VCUG, is based on clinical history, ultrasound results, and specialist recommendations. Treatment. Empiric antibiotics initiate based on local resistance patterns. Commonly used agents include oral cephalosporins or amoxicillin clavulinate, adjust based on culture results. Symptom management. Adequate hydration and analgesia for pain relief. Underlying causes, address any anatomical abnormalities or bladder and bowel dysfunction. Monitoring and follow-up. Recurrent UTIs require further investigation to rule out underlying causes. Imaging, follow-up ARBUS or VCUG may be indicated in recurrent or atypical UTIs to assess for anomalies or VUR. Prevention, hygiene, educate on proper perineal hygiene. Voiding habits, regular urination and complete bladder emptying. Bowel habits, management of constipation. Fluid intake, encourage adequate water intake. High yield points for specialists. Be vigilant for UTIs in pediatric patients with atypical symptoms, especially in the presence of risk factors like CAKUT. Early and appropriate antibiotic treatment is crucial to prevent complications such as renal scarring and chronic kidney disease. Consider underlying anatomical anomalies in recurrent or atypical UTIs and refer for specialist evaluation as needed. Educate caregivers about the signs of UTIs, especially in nonverbal children, and the importance of preventive measures. Pediatric Urinary Tract Infection, UTI Summary. Pediatric urinary tract infections, UTIs, are significant infections involving the kidneys, ureters. Clinical case, recurrent pediatric UTI in a female patient with vesicoureteral reflux, VUR. Patient information, age 3 years, sex, female. Medical history, 2 previous UTI episodes treated with antibiotics in the past year. No significant past medical or surgical history. Presenting complaint. The patient presents to the pediatric clinic with a 2-day history of fever up to 38 point Celsius per 101.3, irritability, and decreased appetite. The mother reports that the child has been urinating more frequently and seems uncomfortable during micturition. Clinical examination, vitals, temperature 38.2 degrees Celsius, heart rate 110 BPM, blood pressure 90-60 mmHg, respiratory rate 20 breaths min. Physical exam. The child appears irritable but is consolable. Mild suprapubic tenderness on palpation. No flank tenderness, no costovertebral angle tenderness, normal external genitalia without erythema or discharge. Investigations, urinalysis, positive for leukocyte esterase, nitrites, and microscopic hematuria. Urine culture, grows Escherichia coli, sensitive to first-line antibiotics. Renal and bladder ultrasound RBUS, normal kidney size and echogenicity with no hydronephrosis. Bladder appears normal. Differential diagnosis. Acute cystitis, acute pyelonephritis, vesicoureteral reflux, VUR with UTI, non-UTI causes of fever and irritability in a pediatric patient, e.g. viral illness. Further diagnostic workup. Given the history of recurrent UTIs, avoiding cystourethrogram is performed, revealing grade 3 VUR on the right side. Diagnosis: recurrent UTI likely secondary to grade 3 vesicoureteral reflux. Management plan: 1. Acute management. Initiate a course of oral antibiotics based on urine culture sensitivity, with a follow-up urine culture after completion of therapy to confirm eradication of the infection. Symptomatic relief with antipyretics for fever and pain management if needed. 2. VUR management. Start prophylactic low-dose antibiotics to prevent recurrent UTIs while awaiting further evaluation by a pediatric urologist. Schedule an appointment with pediatric urology for assessment of the need for surgical intervention versus continued medical management. 3. Parent education. Educate the parents about the importance of completing the antibiotic course, signs of UTI to watch for, and the need for prompt treatment of future episodes. Discuss the implications of VUR, including the potential for kidney damage if recurrent UTIs occur, and the possible need for surgical intervention. 4. Follow-up. Arrange for regular follow-up visits to monitor for UTIs, assess for breakthrough infections while on prophylaxis, and adjust management as recommended by pediatric urology. Plan for repeat imaging, such as a renal ultrasound in 6 months or sooner, if clinically indicated. Discussion points: the significance of recurrent UTIs in pediatric patients and the potential underlying causes, such as VUR, the role of VCUG in diagnosing VUR and its grading, which guides management decisions. The importance of balancing the risks and benefits of long-term antibiotic prophylaxis versus surgical correction of VUR. Vesicoureteral reflux VUR summary. Vesicoureteral reflux VUR is a condition characterized by the retrograde flow of urine from the bladder back into the ureters and sometimes into the kidneys, potentially leading to recurrent urinary tract infections, UTIs, and kidney damage. Etiology: primary VUR, congenital defect in the vesicoureteral junction leading to inadequate closure during bladder contractions. Secondary VUR, results from acquired conditions like bladder outlet obstruction or neurogenic bladder, causing high bladder pressures that overcome the competence of the ureterovesical junction. Clinical features: prenatal, may be suspected with the finding of hydronephrosis on routine prenatal ultrasounds. Infants, present with nonspecific symptoms such as irritability, fever, poor feeding, or failure to thrive. Children, recurrent febrile UTIs, dysuria, urgency, frequency, and incontinence. May also present with hypertension or signs of renal insufficiency in advanced cases. Diagnostics: renal and bladder ultrasound, initial imaging to assess for hydronephrosis, ureteral dilation, and renal scarring. Voiding cystourethrogram VCUG, gold standard for diagnosing VUR, showing the presence and grade of reflux during voiding. Laboratory tests include serum creatinine and electrolytes to evaluate kidney function. Management: medical, prophylactic antibiotics, trimethoprim sulfamethoxazole or nitrofurantoin to prevent UTIs in patients with recurrent infections and mild to moderate VUR. Behavioral modifications: timed voiding and complete bladder emptying to reduce UTI risk. Surgical endoscopic, indicated for high-grade VUR, recurrent breakthrough UTIs despite prophylaxis, or evidence of renal damage. Procedures include endoscopic injection of bulking agents, e.g. deflux at the ureteral orifice, ureteral reimplantation, or creation of a new valve mechanism, e.g. Cohen cross-trigonal reimplantation. Complications: recurrent UTIs, including pyelonephritis that can lead to sepsis if untreated. Renal scarring, reflux nephropathy, leading to hypertension, proteinuria, and chronic kidney disease in severe cases. High yield points for specialists. Early detection and management of VUR are crucial to prevent recurrent UTIs and potential renal damage. Grading of VUR on VCUG helps guide treatment decisions, with higher grades often requiring surgical intervention. Long-term monitoring is necessary for children with VUR, including periodic imaging studies and surveillance for UTIs, hypertension, and renal function. Education for families on recognizing the signs of UTIs and the importance of adherence to prophylactic antibiotics when prescribed. Clinical case, primary vesicoureteral reflux, VUR, in a young boy. Patient information, age, 5 years, sex, male, medical history, 2 episodes of febrile urinary tract infections, UTIs, in the past 6 months, treated successfully with antibiotics. Presenting complaint. The patient presents with a 2-day history of high fever, up to 39.2 degrees Celsius per 102.6 degree Faraps, dysuria, and lower abdominal pain. The parents also report that he has been voiding more frequently and complains of pain during micturition. Under clinical examination, vitals, temperature 39.0 degrees Celsius, 102.2 D Fahrenheit, heart rate 100 BPM, blood pressure 160 mmHg, respiratory rate 22 breaths min. Physical exam, appears uncomfortable and mildly distressed. Suprapubic tenderness noted on palpation, no costovertebral angle tenderness. External genital exam is normal with no signs of discharge or irritation. Investigations, urinalysis, positive for leukocyte esterase and nitrites, microscopic examination reveals pyuria. Urine culture, grows Escherichia coli sensitive to a broad range of antibiotics. Renal and bladder ultrasound, reveals mild bilateral hydronephrosis with no evidence of ureteral dilation or stones. Differential diagnosis, acute cystitis, acute pyelonephritis, primary vesicoureteral reflux. Further diagnostic workup, voiding cystourethrogram, VCUG, demonstrates grade 2 VUR bilaterally during voiding with no evidence of urethral abnormalities like posterior urethral valves. Diagnosis, primary vesicoureteral reflux, VUR grade 2 with acute cystitis. Management plan. 1. Acute management. Initiate a 10-day course of oral antibiotics based on urine culture sensitivity to treat the acute UTI. Symptomatic treatment for fever and pain with acetaminophen. 2. Long-term management. Start low-dose prophylactic antibiotics, e.g. nitrofurantoin at bedtime to prevent recurrent UTIs. Schedule regular follow-ups every 3 to 6 months to monitor for UTIs, assess kidney function, and repeat imaging studies as indicated. 3. Bladder health education. Educate the family on the importance of regular voiding habits, proper hydration, and perineal hygiene to minimize the risk of UTIs. 4. Surveillance for VUR resolution. Plan to repeat VSCUG in 1 year to evaluate for spontaneous resolution of VUR as many cases resolve as the child grows. 5. Referral to pediatric nephrology urology. Given the recurrent nature of UTIs and the presence of VUR, a referral to a specialist for further evaluation and management is recommended. Discussion points. The need for a thorough workup in children with recurrent UTIs to rule out underlying anomalies such as VUR. The role of prophylactic antibiotics in managing VUR and reducing the risk of recurrent UTIs and potential renal damage. The potential for spontaneous resolution of low-grade VUR in children, necessitating periodic reevaluation. Follow-up. The patient is scheduled for a follow-up visit in 1 month to assess response to treatment and adherence to prophylactic antibiotics, with further follow-ups every 3 to 6 months or sooner if symptoms of a UTI develop. Urinary tract obstruction, UTO. Summary. Urinary tract obstruction, UTO, represents a spectrum of disorders characterized by an impedance to the flow of urine due to mechanical or functional blockages at any level of the urinary tract, from the kidneys to the urethra. Etiology, upper UTO, renal, nephrolithiasis, carcinoma of the renal pelvis, ureteral, nephrolithiasis, ureteral strictures, ureteral carcinoma, extrinsic compression, e.g. tumors, aneurysms. Lower UTO, bladder carcinoma, neurogenic bladder, bladder tamponade, urethra, prostatic enlargement, posterior urethral valves, urethral carcinoma. Clinical features: acute, severe, colicky pain, renal ureteric colic, hematuria, nausea, vomiting, oliguria, anuria, urinary retention, suprapubic pain, and palpable bladder. Chronic, often asymptomatic, hypertension, features of chronic kidney disease, CKD in bilateral UTO or UTO in a solitary kidney. Diagnostics, laboratory tests, CBC, basic metabolic panel, BMP, urinalysis. Elevated creatinine indicates renal failure. Imaging, ultrasound, initial test for hydronephrosis, dilated ureter, and assessment of renal and bladder anatomy. Urodynamic studies for suspected neurogenic bladder. Specialized imaging, CT, MRI, or nuclear medicine scans for detailed evaluation. Treatment, emergency management for acute kidney injury, sepsis, refractory pain, dehydration, or complete UTO. Immediate intervention with bladder catheterization, ureteral stenting, or percutaneous nephrostomy. Chronic management, address underlying cause, e.g., surgical removal of stones, treatment of strictures, prophylactic measures for recurrent causes like nephrolithiasis, long-term management of complications like CKD. Complications, pyelonephritis, obstructive nephropathy leading to CKD, nephrolithiasis, bladder trabeculation, and acute kidney injury. High-yield points for specialists. Early diagnosis and intervention in UTO are crucial to prevent irreversible renal damage. Comprehensive evaluation, including both laboratory and imaging studies, is essential for accurate diagnosis and localization of the obstruction. Individualized treatment based on the cause and severity of the obstruction, with multidisciplinary management involving nephrology, urology, and potentially interventional radiology. Continuous monitoring for complications, especially in chronic or recurrent cases, to mitigate the risk of long-term renal impairment. Clinical case, bilateral hydronephrosis due to ureteropelvic junction obstruction in an infant. Patient information, age 6 months, sex male. Medical history, prenatally diagnosed with bilateral hydronephrosis, normal birth history and development milestones thus far. Presenting complaint, the parents bring the infant for a follow-up visit concerning the prenatal ultrasound findings. They report episodes of inconsolable crying, which they suspect might be related to pain. Clinical examination, vitals, within normal limits for age. Physical exam, the infant appears well hydrated and in no acute distress. A palpable mass is noted in the left flank region. The rest of the physical examination is unremarkable. Investigations, renal and bladder ultrasound, RBUS, confirms bilateral hydronephrosis with severe dilation of the left renal pelvis suggestive of ureteropelvic junction, UPJ obstruction. Right side shows mild to moderate hydronephrosis. Voiding cystourethrogram VC no vesicoureteral reflux, VUR. Bladder appears normal. Renal scan MAG3 reveals delayed drainage from the left kidney consistent with UPJ obstruction. Right kidney shows mild delayed drainage, but to a lesser extent. Differential diagnosis, ureteropelvic junction obstruction, vesicoureteral reflux, excluded by VEG, ureterovesical junction obstruction, neurogenic bladder, less likely given age and presentation. Diagnosis, bilateral hydronephrosis secondary to UPJ obstruction, more severe on the left side. Management plan, 1 surgical consultation, referral to pediatric urology for evaluation of surgical intervention, particularly on the left side to relieve the obstruction and preserve renal function. 2, conservative management. For the right side, consider conservative management with close monitoring given the milder degree of hydronephrosis. 3, symptomatic management. Pain management as needed, although it can be challenging to assess pain accurately in infants. Observations of pain episodes and parental reports can guide management. 4, antibiotic prophylaxis. Given the obstructive nature of the pathology, start low-dose antibiotic prophylaxis to prevent UTIs until definitive treatment can be carried out. 5, follow-up and monitoring. Regular follow-up visits with repeat RBUS every 3 to 6 months to monitor hydronephrosis progression and assess renal function. Monitor for signs of UTIs or worsening hydronephrosis. Discussion points. The significance of prenatal ultrasound in identifying potential urinary tract anomalies and planning postnatal care. The importance of differentiating between surgical and conservative management based on the severity of obstruction and renal function. The role of regular follow-up and imaging in monitoring the progression of hydronephrosis and preserving renal function. Follow-up. The infant is scheduled for a follow-up visit in 1 month with the pediatric urologist to discuss surgical options. Parents are educated on recognizing signs of UTIs and the importance of adherence to antibiotic prophylaxis.